This is a patient bothered by poor vision after light adjustable lens surgery. The lens has annular haze and she's already been YAG lasered. And she actually works for an ophthalmologist and she's been referred for treatment. So we've decided to exchange this lens for her. And because she's had a YAG laser, we're going to go ahead and do a pars plana vitrectomy. She has not had a posterior vitreous attachment, so we're going to go ahead and induce a PVD when we do the vitrectomy. So here we're making a generous incision because these lenses are rather thick and chunky, and when you cut them, they tend to fragment. So you want to keep everything together so pieces don't fall back when you cut the lens and try to pull it out. So here we're pulling the lens out of the capsular bag remnant. We visco-dissected that remnant open, and we're rotating the lens out of the capsular bag into the anterior chamber. And I'm going to go ahead and grab this with a serrated microforceps. This is an MST 19 gauge Packer Chang scissor. And as I hold the lens and start to cut it, I can feel it kind of wants to fragment or shatter. So I want to keep all these pieces together, and I'm going to re-grab it and try to cut down the middle as much as I can, and you know, keep the pieces together. When I pull the lens out, I make a generous incision so that the lens doesn't fragment as I pull it out. It just slides out easily. If it starts to fragment and shatter, then you're going to have trouble uh, pulling those thicker central pieces out. So now I'm going to go ahead and do my pars plana vitrectomy. And this patient has had femtosecond cataract surgery. So the rhexis edge is a bit brittle, and you can see this little splinter here in the edge of the rhexis. And that's going to want to tend to run out when I try to optic capture the lens, the new lens. So what I want to do is use a 25 gauge vitrector to sort of erase that splinter, just uh, file that away, so to speak, so that the edges of the rhexis are smooth again and won't have a tendency to run out. So now that that's done, I'm going to go ahead and do my posterior vitrectomy with posterior visualization, a light pipe. And this patient hasn't had a posterior vitreous detachment, so I'm going to stain the posterior hyaloid with dilute Kenalog and then induce posterior vitreous detachment. This woman is rather young, and if I don't do this, she'll end up having a PVD and having floaters and more risk of retinal detachment down the road. So we'll just take care of this now. And what I'm doing is using the vitreous cutter to pull the posterior hyaloid off the optic nerve and then start to cut. And this will lift off, and here I've induced posterior vitreous detachment, and now I can chew up this posterior hyaloid using the vitrector with the cutter on. The cutter is turned off when you pull the vitreous off the optic nerve. There's a little tiny remnant of posterior hyaloid that I remove and complete the vitrectomy, moving out to the periphery. Once the peripheral vitreous is removed, I do scleral depression to make sure that there's no holes or tears. You can see this on the right side here, the indentation in the sclera as I shine with the light pipe. And things look very good, so I'm going to go ahead and inject a three-piece silicone Li61AO in the sulcus. I'll rotate this into position, optic capture the right side behind the anterior capsule, then rotate a little bit and push down and optic capture the other side. And now the lens is very securely optic captured behind the anterior capsule. I'm going to just give a little nudge here, and you can see the nice optic capture and good centration. I placed a 10 nylon suture because my incision is a little bit bigger than 3 millimeters, and I don't want to induce any astigmatism. Remove the trocars when the case is completed. The next day, the patient was 20/25 uncorrected and very happy with the outcome. Here's the comparison to what the previous light adjustable lens looked like in the eye. Thank you for your attention to this case.